Everyone, and welcome to the University of Toronto Spine Program Journal Club on COVID-19. I'm Michael Fehlings. I'm a co-director of the University of Toronto Spine Program, and I bring greetings to you from Toronto, along with my a colleague and co-director, Dr. Albert Yi. We thought we might begin with a few opening remarks from Professor Yi, just to tell you a little bit about the University of Toronto Spine Program, and then I'll go ahead and then introduce this special session on COVID-19. Albert.
Thanks so much, Michael, and welcome everyone this afternoon in Toronto. So I can't bring you Toronto physically, so I've got a virtual photo of Toronto in the background. And I think from judging from those that have registered for the webinar, it's great to be able to welcome our surgeon colleagues, our alum. We have many fellows nationally, internationally, as well as our trainees. We have folks from our interprofessional team as well as scientists. And so we're obviously all sort of in this era sort of together. And I think it's a great opportunity for us to learn from each other and to gain some additional insights. And Michael will introduce some of our speakers a little bit more formally, but I think we're very privileged to have some world-renowned experts in this evolving, rapidly evolving field with some personal experiences. And I think we're poised to gain a lot of insights from them this afternoon and into the early evening. As Michael has mentioned, this webinar is part of our academic calendar of events for our UofT spine program. And this is a university-based program which basically brings together the various hospitals around the city with a common clinical, academic research, as well as education interest in spine and spine care. Typically we have approximately 14, 15 fully dedicated academic spine surgeons on faculty at 4 of the hospitals around the city in Toronto. We typically have about 13 to 15 clinical fellows each and every year. Half of our fellows are typically from international backgrounds, and half typically trained in Canada as part of their residency. And this program brings together both neurosurgery as well as orthopedics, along with our interprofessional colleagues and scientists in related efforts. The program is very much built around our trainees, and there's a lot of venues, including journal clubs and sort of special webinars like we're having today. And we also have a few, I guess, at times where personal contact was a little bit more permissive, sort of quarterly hospital-based visiting professorships, where we would basically showcase some of the spine activities at each of the hospitals in and around the city. So with that, again, welcome, and I very much look forward to the presentations. And I guess, Michael, did you want to provide a bit, I guess, more instructions in terms of question and answer and things as we move towards our presentations?
Thank you, Albert. So I'll make a few opening remarks, and then we'll perhaps just we'll orient the audience briefly in terms of how to ask questions. So we're in unprecedented era, and we pandemics are not necessarily a new phenomenon if we look at history, but certainly in the modern era, we truly are in an unprecedented set of circumstances, and this has truly affected us all at a global level. And this evening, we have a number of people that will be contributing. I'll introduce them sequentially, but we have Dr. Alon Vaisman, who brings in infection control expertise. We have Dr. Yongchao Wu, who is from Wuhan and himself was affected by COVID-19, and he'll talk to us about his experiences personally and professionally. And then we have two of our trainees, Dr. Reinmuller from Austria, who will be talking along with one of our neurosurgery residents, Dr. Ali Moghaddamjou. And Nadia, were we going to show some slides in terms of how to handle the questions and answers? Yes. So basically, you have a couple of options. So either you can raise your hand, but it's probably preferable to actually type in your questions, and then for the first part, I will do the moderation, and for the second part, Dr. Yi will do the moderation, and we'll try to transfer the questions over to the speakers to handle the discussion. So I'd like to at this point introduce our first speaker, and we're privileged to have Dr. Alon Vaisman. Alon is an assistant professor in the Department of Medicine at the University of Toronto. He's an infection control expert, and he works at my unit in Toronto, which is the University Health Network. And professionally, Dr. Vaisman also has a background in clinical epidemiology. And Dr. Vaisman will talk to us a bit about the current understanding of COVID-19 transmission and infection. Alon, over to you.
Sorry, thank you to Dr. Fehlings and Dr. Yi for inviting me for today for the speaking here, and thank you, Nadia, to organizing this. So we'll just start with the slides, Nadia. So we'll start with a little bit of background on the infection, and then we'll move on to the modes of transmission, and then other things related to transmission of the infection. So the COVID-19 is caused by, as many of you know, SARS-CoV. We don't have to do a lot of the background on the infection itself, because I think a lot of you are aware of where the infection originated. Just so that you know that there's many other coronaviruses that we're aware of, and 4 of them cause the mild infections that we see that cause the common cold. There's about 10 to 15% of all the common colds are caused by these. Then there's the 3 severe strains, which we know about: MERS, which is Middle Eastern Respiratory Syndrome, which comes from the Middle East, the Arabian Peninsula; SARS-CoV-1, which originated in China in 2002, and then SARS-CoV-2, which also originated in China this past year. So next. Well, many of you also have been trending the way that this infection has progressed, and of course, there's lots of discussion about flattening the curve, and you can see where Canada is currently. As of data from yesterday, we see that Canada has not quite reached the peak of its cases right now compared to other countries. We're very similar because Canada's first case was approximately the same time as other countries' first cases. And of course, China, which was the first country initially hit by the epidemic, has now leveled off in terms of their cases. Next, you'll see the cases specifically in Canada and in Ontario. So we see that the new deaths and new daily cases here in Ontario has also started to level off. And there is some reassuring data now that in Canada, things are close to the peak. And specifically here in Ontario and in Toronto, things are perhaps reaching their peak and coming down a bit more. So how do we diagnose this virus? Next, you'll see some, currently the gold standard is to do nasopharyngeal swabbing, but there's, sorry, that got cut off there, but there's other sites that we can also test, including the oropharyngeal sampling, BAL, sputum, blood, and feces. And on the next slide, you'll see the sensitivity of this testing that we use for the first PCR that we use for nasopharyngeal swabbing. So this is the gold, not so much the gold standard, but the standard of testing in the majority of places across the world. And these are some studies that have been done initially to look at how sensitive that test is. So as clinicians, we all ask ourselves, if we suspect a case in a patient who's presenting to the hospital, how can we rely on the first swab that we do on the patient? As you can see, the gold standards that were done in these tests were not necessarily like a gold standard that we would rely on for other kinds of respiratory viruses. For example, biopsying the lung or doing a bronchoscopy. We've had to rely on other kinds of ways to tell whether it's a reliable test In this case, they've tested other parts of the body and have used that as a gold standard. You can see the sensitivity ranges from 70 to 90% based on these initial studies. But of course, the best gold standard test would be to compare it to a nasopharyngeal swab to either a biopsy of the lung or something like a lower respiratory specimen. So next, we're going to move on to discussion on the neurological involvement. Perhaps maybe this will be discussed further later, but there is very early preliminary data looking at neurological involvement caused by SARS-CoV-2. Initially, with the first SARS that was seen in 2002, there was some initial thought about virus causing neurological symptoms, including central nervous and peripheral nervous system issues. We have some very, very early preliminary data looking at seeing cases of Guillain-Barré caused by the infection. And on the next slide, you'll see this a second paper that came out in New England Journal of some neurological symptoms that were discovered. Specifically in this cases were patients who had ARDS. So you can imagine these patients are more sick than the average patient with COVID. 80% of people with COVID have actually mild disease. Those are very sick individuals who had some, as you can see, some specific abnormalities. Notably, all of the patients in this case series had negative CSF PCR samples, but there is already a case report, and I think even more than one, of several by now, of people actually having positive SARS-CoV-2 in the CSF. So it's not a common finding as far as we know, but as the pandemic progresses, we're going to see more of this occurring. That's just a very brief overview of the kinds of neurological abnormalities you can see listed there. But of course, this is very, very early, and it's not the primary site of infection, so we're going to see more and more of this come out as more studies come out. So next, I'll be discussing the modes of transmission. So the modes of transmission that we talk about in infection control, there's three. The first one we'll see is contact, and this is called, we place people under contact precautions. And where I'm going with this is trying to explain to you how COVID is actually transmitted in a hospital setting. In these cases, contact infections or infections transmitted by contact are those that you have to actually make direct contact with the infected material. And most of these are infections that are transmitted through stool, so through fecal oral route. There's other multi-drug resistant organisms, as well as even severe organisms that cause severe infections like Ebola. Next is, we move on to the next is droplet precautions. So this is a critical thing to understand about COVID that we'll get into in just a second. But if somebody has a respiratory virus, they are able to generate a large droplet through coughing and sneezing that is approximately 5 microns or greater, that can go out into the body and drop approximately 6 feet away. In other words, it's not small enough that it could be transmitted through the air and be able to disperse throughout a room. The smallest droplets will end up being able to transverse the room in a more broad way, but infections that are transmitted through droplet cannot do that. They can't survive in a suspended droplet in the air, and they can't survive in these very tiny micron-sized droplets. So what are the infections that are transmitted through this droplet route? On the next slide, you'll see these are very common infections: viral respiratory infections, some bacterial upper respiratory infections, and meningitis. And we maintain at least a 2-meter space between patients as a result, and we use droplet precautions for this. On the next slide, you'll see the other form, the last form, the third one, airborne. And this is where all the controversy about transmission for COVID comes, is that people initially suspected there might be an airborne transmission of the virus. Unlike droplet, the infections that are transmitted via airborne are transmitted through very tiny particles. So things that are less than 5 microns, which we either call droplet nuclei or aerosols. In other words, a large droplet greater than 5 has evaporated into a very small aerosol, and this can carry itself throughout the room or into ducts or even outside the room through just the currents of the air. There's only 3 infections that we know about in all of our interactions with infectious diseases, and those are TB, chickenpox, and measles that are carried through airborne. There's no other infection that we know about that's carried through this route of transmission. In these cases, we use negative pressure, and we ask all healthcare workers to don an N95 in order to prevent these aerosols from entering the healthcare worker from inhaling it. So what is COVID? How is COVID transmitted? This is really critical. The best available evidence that we know about now is that COVID-19 is transmitted through droplet and not through airborne. And this is a very critical piece to understand in terms of what PPE, what personal protective equipment we should be wearing when we see patients with COVID-19. This is supported by multiple agencies across the world, including WHO, including the Public Health Agency of Canada. So what is the evidence for this? We'll go over that evidence in just a second, but I just wanted to also clarify a point I made earlier, is that large and small droplets is an oversimplification of the situation. There's likely a continuum of size droplets that are generated as a result of the infection, as a result of somebody coughing or sneezing. It's just that you have to think about what is the most predominant form that is produced as a result of somebody coughing or sneezing. So that's the important thing to keep in mind. And a lot of the data that we have to prove that this is a droplet transmitted infection is very indirect. So let's take a look at the first level of data. So if you go back one slide, the first evidence that we have is based on biological plausibility or analogy. So that's basically, as I mentioned earlier, all the infections known, all the respiratory viral infections are all transmitted through droplet. All the coronavirus infections that we know of are also all transmitted through droplet. So just based on the analogy and based on plausibility, it's likely that this is the likely mode of transmission. Next, we have early experience. So if you think about, going back to the early experience slide, we know that the infection, if an airborne infection is known, those infections are transmitted in a very high volume in a population that's susceptible. So for example, measles is an airborne infection. It's the single most infectious disease known to humans. Its reproductive number is up to 18 in the susceptible population. And for tuberculosis, in a population of susceptible individuals, over the course of 1 year, it's up to 10. But the reproductive number for influenza is much lower. So analogous to COVID, which is also similar in that similar range. So just by understanding the reproductive number, we get a sense of how infectious it is, and it is likely it is transmitted to droplet based on that. Also, we see relatively low attack rates in household compared to airborne infections. That's not to say that you haven't seen large clusters in households. That is a very important method of transmission of the virus. So for example, studies have shown that about 10 to 20% of people in a household will be infected by COVID if one person has it. It's just that this value is lower than other areas, than other infections that are transmitted through airborne. The other thing is that areas around the world where droplet contact have been used and not airborne, we haven't seen large-scale outbreaks. So just based on that, another piece of evidence suggesting that it is likely transmitted through droplet and not through airborne. So the next piece of evidence that we have is the anecdotal data that we've seen when we've seen even low risk of infectivity among healthcare workers who weren't wearing N95s, even during an AGMP, and I'll show you the data for that a little bit later. Another interesting case is of the airplane that was carrying the first case of COVID to Canada, of around 250 people in an airplane. No other confirmed cases were found, and you'd expect over the course of a 12-hour flight, if the infection was in fact airborne, we'd see more cases, but that wasn't. Then there's other other studies where they've done air sampling to look at whether the infection can be transmitted in the air. And these are very small anecdotal studies with small case series, and examples are here, but there hasn't been evidence to show that the virus can survive the airborne transmission that we see with other airborne transmitted infections. Next is environmental experimental data where people have tried to aerosolize the virus and see whether it can carry. So we've definitely seen that in experimental settings where intentionally the virus is aerosolized, it can survive. But in non-experimental settings, we haven't seen a contamination of the air to suggest that the virus can survive in these settings. So for example, we can find PCR positive air samples in the room of a patient, but none of these virus particles are found to be viable. None of them are found to be able to actually attack a cell. So in the next slide, you'll see this study that was published in the New England Journal where they looked at aerosolization. First, they aerosolized the virus. They found that the virus can survive for 3 hours or so. But again, this was not a clinical setting. This was all experimental. And the other piece of information that you see here is that they looked at how long the virus can survive on surfaces. It could survive up to 3 days on certain surfaces, including cardboard or stainless steel. But again, this was in an experimental setting. So in experimental settings, the virus can aerosolize and survive, but in clinical settings, this has not been demonstrated. So next, I will talk about personal protective equipment. So what does this mean for you? Everyone I'm speaking to you here is frontline healthcare workers, physicians, or otherwise who will be seeing patients with COVID. So what is the protective equipment that you need to wear to protect yourself against COVID? So we talk about commonly the PPE being gown, gloves, face protection, and procedure mask. And this is what we use at our hospital, for example, is a simple rubric to help identify what the correct PPE is. But these four are really the mainstay of PPE to protect yourself against COVID. And what is the proof for this? Well, aside from what I gave you earlier regarding all of the indications that this is a droplet contact transmitted virus, we also have other papers cited down here of SARS that show that these were protective. If you looked at healthcare workers during the SARS pandemic that did wear these protective equipment versus those who didn't, there was a lower rate of transmission among the ones who did wear it. So this shows that this level of protection is adequate against the virus. There hasn't been yet a comparison of the N95 versus these PPE for this specific virus. But if we use the analogy of SARS, then we could be confident for now that this is protective. So next, I just want to talk about masking. Why do we wear masks? This is a very common question that comes up in many countries, but whether we should be wearing masks outside of the hospital and what's the appropriate mask inside. There's two goals of wearing a mask. One is to prevent the source from transmitting. The other is to prevent the healthcare worker from acquiring the virus. So if we look at the types of masks on the next slide, we see how we break these down. There's level 1, 2, and 3. These are a standardized level that we use to designate what's the appropriate level mask to wear. All procedure masks are adequate for protection against COVID-19. The only difference is that there is a different level of protection for a spray. And this is relevant to surgeons because only the level 3 provides the highest level. As you can see, there are 160 millimeters of mercury against a spray. So if you're looking after a patient on the wards, you're not likely to experience a high pressure spray from even a venous or arterial blood splash. But if you're doing a procedure in the OR, and let's say you're doing a high rapid drill, for example, you're drilling into a bone, you need to be wearing the level 3 in order to protect you against the high pressure spray. But again, this is not specific to COVID. This is true for all infections. Any bloodborne infection, for example, you'd wear the level 3 mask. But any other kind of care you're providing, let's say on the ward, any level is adequate. And these are for procedure masks and for surgical masks. So next, we'll talk about, on the next slide, N95. So there's been a lot of discussion about whether you should wear an N95 for a patient who has COVID-19. These N95 respirators are only used for patients who are under airborne isolation, so the 3 infections I mentioned earlier, or if you're performing an aerosol generating procedure, which we'll talk about in a second. These N95 respirators are fit tested, they form a tight seal around your face, and they have a high filtration against airborne particles of greater than 95%. That's what the 95 stands for. The difference between the N95 respirator and the surgical mask is that it is fit tested to you, and so it prevents even the tiniest aerosols that I spoke about earlier, the ones less than 5 microns, being able to get inside and cause an infection. They also have a very high bacterial filtration, which is helpful, of course, if you're doing just routine care as well. So if anyone has wondered what does the N stand for and what does the 95 stand for, here is a brief summary of what those mean. N stands for not resistant to oil, R is somewhat, and R is somewhat, and P is strongly resistant. In other words, there's complete resistance to oil. In the healthcare settings, it's irrelevant whether your mask is resistant to oil or not. This is only relevant to people working in factories. But in any event, if you wanted to wear an N95, an R95, or a P95, you'd be just as protected. You might see these being used on the wards in your hospitals as a last resort if we run out of N95s, but they provide the same level of protection. These P100, this is an example of a P100 that I show you here on the right side. So just in case you see these in your hospitals, just be aware what the N, the R, and the P stand for. And again, the N95, that stands for the airborne filtration. So it's able to filter 95% of airborne particles that come towards you. All right. So I see there's some questions. Maybe I'll just address one of them right now. During spine procedures, my glasses are fogging up with N95s. This suggests that the N95 is not filtering correctly. So sometimes your goggles will fog up because you're breathing. There's some moisture that goes into the goggles as a result of you breathing near them. It's not necessarily mean that there's particles getting inside. The way that an aerosol transmitted infection will infect you as a frontline staff is through inhalation. It's not typically through contact with the eyes. In any event, the goggles that most people use are quite able to seal off any aerosols from entering. But even if they didn't, the main concern that we have here with these tiny aerosols is through inhalation. So as long as you're wearing the N95, it is doing a good job. You should for sure make sure that there's a seal. When you don your N95, do a seal test where you, of course, you pinch the nasal bridge and you test if the air is coming out. So you just breathe out and feel it against your hands. If you're feeling air leak out, then you should make sure that the N95 is fitted even better to your face. And if it's not working, then you need to go get fit tested again. So do we need to be using surgical masks do we need to use N95s when we're looking after patients? Based on data from influenza and other respiratory viruses on RCT and a systematic review, N95s and surgical masks are equivalent. So for routine precautions and droplet contact precautions for patients with COVID, you don't need to wear the N95. The N95 is strictly for the aerosol generating procedures that I mentioned earlier. So now we can talk about what those aerosol generating medical procedures are. So this is a commonly used term that it's very important for you to understand when you're looking after these patients. So what are aerosol generating procedures? So these are the procedures that can induce these tiny nuclei. So whereas routine care of a patient under droplet contact, when they're coughing and sneezing, they're not producing many of these tiny droplet nuclei. When you're doing aerosol generating procedures, you're manipulating the airway either at a high pressure or at a high speed, such that you can start generating these tiny aerosols. And that's why you need to wear the N95. So patients under COVID isolation, what are aerosol generating procedures that we might do on them? So on the next slide, you'll see a big list of aerosol generating medical procedures. Intuitively, some of these make sense. You're manipulating the lower part of the airway. You're causing a deep cough in some of these cases. You're infusing a high pressure into the airway, like in BiPAP. Intubation can be an aerosol generating procedure, especially if it's not elective. So if you're attending to a code, for example, the patient is not sedated, not paralyzed, there's potential for aerosols to be generated. In the OR, it's less likely for that to be the case when you're doing an elective procedure because the patient is sedated and paralyzed, so there isn't going to be a lot of coughing in that scenario. In any event, if the patient does have COVID, you would be wearing an N95 in that setting. I should also say that you would not be doing a lot of these AGMPs on COVID patients. You don't want to be exposing yourself unnecessarily. So in most hospitals, only intubation and extubation is done on these patients, and we avoid all these other ones unless it's absolutely certain that we have to do them. So BiPAP, manual ventilation, bronchoscopy, these are all avoided in COVID positive patients. There's been a lot of controversy about what isn't an aerosol generating procedure. So you'll see on the next slide what that list is. A lot of societies across the world are developing their own guidelines of what an aerosol generating procedure is because of the concern around COVID. But really none of these were considered aerosol generating before COVID, and the science around them hasn't changed. One exception might be ventilator circuit disconnects where there potentially is a spray, or that's kind of controversial. But the majority of these other ones you won't see on the list for, let's say, the WHO or the Public Health Agency of Canada or the NHS, for example, in Britain. You won't see these on their list of aerosol generating medical procedures. So, and the basic reason is, as I explained earlier, they're not procedures that are causing a rapid or high pressure manipulation of the airway. Okay. So next, this is an interesting study that I referred to earlier in Singapore, where they looked at exposures to healthcare workers who were not wearing an N95 for the most part, about 85% of this 41 people. During an aerosol generating procedure, actually, they had intubation, extubation, BiPAP, and only later were they discovered to have COVID. And all of these healthcare workers were exposed, and none of them were infected. So 35 or 38 of them were wearing surgical masks, and they weren't infected by the virus. I'm not saying you shouldn't wear an N95 for these procedures. I'm just saying that it's an interesting case series to show the actual likelihood of transmission of COVID in these high-risk settings. So just to give you a sense that wearing a surgical mask, wearing a procedure mask is sufficient to protect you against patients who have COVID for routine care. All right. So as I mentioned, you want to avoid these procedures on COVID patients. In these protected code blue scenarios or any code blue where you're doing on a COVID patient, you'd want to wear these. If necessary, you have to wear an N95 in a negative pressure room, and you should allow 30 minutes after the procedure to allow for proper air exchanges. So again, because you're aerosolizing, you want to make sure the air is cleansed of all of these aerosols that are infected by COVID. The last point I'll make is that point of care risk assessment is crucial. If you're looking after a patient and you're anticipating an aerosol, an AGMP to be done, you should don an N95 to protect yourself. So So in other words, if the patient's deteriorating, if they're crashing and you expect there need to be an intubation, you should wear the N95 in anticipation of that happening. Okay, that's a really critical point of all infection control guidelines, is that you should always be doing the point of care risk assessment anytime you're seeing a patient. All right. So in conclusion, the best available evidence suggests that COVID-19 is transmitted through large droplets. You should wear gown, gloves, procedure mask, and face protection for routine care. In other words, all droplet contact, and then an N95 for AGMPs, and recognize when an AGMP may be done. And I touched briefly on the neuromanifestations, but this is very early data that we're looking for, and more data is going to come out soon about this. Thank you very much for inviting me, and I'll take questions from the audience.
Thank you, Alon. That was excellent. So there are a couple of questions. So one related to aerosolized procedures relevant to neurosurgery and spine surgeries. So often to access the brain or the spine, we're burring bone tissue, or we may be making a drill in the skull with a perforator. And this could generate dust with some blood that might be aerosolized. Would this be considered an aerosolized procedure in your judgment?
So it's not known whether the COVID virus itself is in the bone, but certainly can be found in the blood. And of course, when you're doing these procedures, it could be messy and you're going to aerosolize a variety of tissues. If you have a patient with COVID, and again, most of the time these procedures would be avoided altogether, but if you did have a patient, then yes, these would be certainly aerosolizing. Any procedure where you're doing rapid drilling into the bone can potentially cause aerosolization. And in anticipation, you'd wear the N95. The other relevant procedure for neurosurgeons is entry of the head and neck or through the nose to do any kind of sphenoidal access into the brain. Then yes, that would also be considered potential aerosol generating. Although this hasn't been specifically studied, in theory, this could be a potentially higher risk since you're entering the airway. And an N95 would make sense to don in that case as well for patients who have COVID. Absolutely.
Okay, thank you.
And I see there's a question here about the sensitivity. So that's, sorry, I'll just read it out. There's a question about the sensitivity of testing is 62% and therefore should be wearing PPE for all COVID negative patients. Do you think this is a correct course of action or wasteful of PPE? So as I mentioned, our best assessment on the sensitivity of the test is probably around 70 to 90%. However, there are going to be patients that you're looking after where you're going to have a high clinical suspicion, in which case, just like other things, you should be ordering a second test if the suspicion is high enough. In speaking about whether or not you should wear PPE for all patients, in Toronto and in Ontario, many hospitals have already moved to universal PPE use in order to prevent transmission even from the asymptomatic patients or those you think are negative. So for example, a surgical mask is now donned universally in most Toronto hospitals. And also now at our hospital and many others, a face shield is also being donned universally in order to prevent transmission. This might be different in the hospitals that you work at across the world, but that is one way to try to avoid transmission. And I don't think that's necessarily a waste of PPE. I think it makes sense as the prevalence of the disease is rising in the community and we're not able to pick up a lot of it. Donning a face shield and a surgical mask for all patient interactions, I think is it's good protective care for the healthcare workers.
If there are any other questions, I would ask the audience to type them in. Oh, there's another question here. Alon, this relates to what do you think the standard of testing should be? Every patient who comes into ER, regardless of symptoms, versus only symptomatic patients picked up with screening questions, and should all healthcare professionals be tested?
That's a very, very tough question. It's a very controversial question. If we start first with the patients, there's a lot of drawbacks to swabbing all patients as they enter the hospital. One is the negative patients. It's important to recognize the negative swab is only as good as the day you do it. And the reason is that the patient could be incubating the virus. So you haven't necessarily ruled things out if they are completely asymptomatic. Then secondly, they could also be false negatives, as was mentioned earlier. The other thing to recognize is if a patient swabs positive, you're looking at 3 potential groups who are swabbing positive. One is the pre-symptomatic people who are about to develop the disease, who have actually very high viral loads, who you do want to recognize in order to isolate them. The second is the people who are post-symptomatic, who had the virus, who had some kind of mild illness, who are now getting better. And the third is people who are going to be asymptomatic throughout the entire disease. So for whatever reason, they had the disease but never manifested any symptoms. Obviously, the difference between the three is very significant in terms of their outcomes in hospital, as well as their ability to transmit. Currently, we don't know the answer to the question of how are these people transmitting the virus. We think that the first group are very high risk, but we don't know for certain. So the challenge of swabbing everyone is understanding the positives, understanding the negatives, and the third thing is the resources. You know, do you have enough single rooms, PPE, swabs, and assays to do that? So I think that the answer to that question depends on all those three and your ability to be able to properly do it. Perhaps in a perfect world with unlimited resources, we might be able to do it, but right now it's not very feasible. The same limitations apply to healthcare workers. How do we interpret that negative swab in a healthcare worker? And how many times we have to swab that healthcare worker to actually get reliable, informative data? I think that's something that's moving forward in many settings. For example, in long-term care settings in Ontario, all patients and all residents and all healthcare workers are being swabbed. You may see that being moved out into other settings as well.
Okay, appreciate that. Well, Alon, thank you. That was excellent, and I hope we'll have some time at the end for some further discussion. So next, I'd like to introduce Dr. Yongchao Wu. And Yongchao is an associate professor in the Department of Orthopedics at Union Hospital in Tongji Medical College at Huashuang University of Science and Technology in Wuhan. And Yongchao spent time in Toronto as a research fellow with us at Toronto Western Hospital. He did some excellent work in basic science of spinal cord injury. And Yongchao has been working as an orthopedic spine surgeon at the nerve center, if you will, of the corona crisis in Wuhan. Yongchao himself contracted COVID-19, fortunately is okay, and his family's okay. But his department clearly faced many challenges, and he's actually put together an article, which was among the reading list, documenting his experience. So Yongchao, thank you very much for participating. What time is it currently in Wuhan?
It's 5 a.m.
5 a.m. Okay, okay. A civilized hour for a spine surgeon, I'm sure.
Yeah.
Okay, over to you, Yongchao. Thank you very much.
Thank you, Dr. Fehlings. Okay, let me share my slides. Is it okay with my slides?
It's perfect. We can see it very well. Thank you.
Okay. Yeah. Hello, everyone. I'd like to thank Dr. Fehlings and Dr. Ye for invitation. Today, I will share my results from my search of COVID-19 among orthopedic surgeons in Wuhan, China. As we know, coronavirus disease 19 is affecting more than 200 countries and infected 3 million people around the world. At the beginning of the pandemic, China was the most affected country, and Wuhan was the epicenter 3 months ago. Wuhan is the Chicago of China and the largest city in central China. Wuhan is a national transport hub, and the population here is 11 million. Wuhan is a city with history and culture. We have more than 1 million university students in the city. Dr. Fehlings was invited to visit our city in 2016. The first cases of the COVID-19 in China were linked to the Huanan seafood market. This market sold wild animals like pangolin. The pangolins are thought to be an intermediate host of the virus, and the flake of the pangolin could be used for traditional Chinese medicine, but we don't eat that. My hospital, Wuhan Union Hospital, is just 5.8 kilometers from the Huanan seafood market. The first reported suspicious COVID-19 patient of Wuhan visited my hospital in December. And the Union Hospital is one of the largest hospitals in Wuhan. It's very busy with the visits over 3 million each year. Dr. Fehlings was invited to visit our hospital in 2016. He gave several speeches and met our president of the hospital. The Union Hospital was in the first line to fight against the COVID-19. We admit 5,200 COVID-19 patients, and we have 23,000 visits in the Vivo Clinic, and we did online medical service up to 80,000 patients. And our hospital was in charge with 2 stadium hospitals, worked together with 20 medical teams from other provinces of China. This kind of hospital are special for patients with mild symptoms to stop transmission in the community. My colleagues did some trauma cases with COVID-19. During the operation, surgeons used personal protective equipment and some disposable tools. These patients recovered well. During the fight with COVID-19, the President of China connected with our hospital to support the fight. I got infection of the COVID-19. Here's my clinical information. The onset of symptom was on January 31st. My symptoms were fever, cough, and diarrhea. Check the CT shows ground glass opacity and consolidation. I did 5 times of nucleic acid test, but all of these are negative. And I had a positive antibody test for IgM and IgG in the middle of February. Now, the IgM negative and IgG it's positive. I took antivirus drugs. The symptoms disappear in 5 days, and I have a self-isolation in a hotel for 35 days to avoid transmission to my parents and the kids. I had low transmission to others. My exposure history was not clear. There were low cases in my community at that time, and there were some cases in my hospital since late December. So I think the exposure must be in the hospital. And I want to figure out why and how I got infection, so I did a study. The purpose of the study is to identify the risk factors at the personal level of orthopedic surgeons infected with COVID-19 in Wuhan. We use a self-admit questionnaire to collect information and we used a matched case control study to explore the risk factors. And the results show we infected 24 hospitals in the urban area of Wuhan. A total of 26 orthopedic surgeons with COVID-19 were identified from 8 hospitals. The number of cases in each hospital varies from 1 to 8, and the incidence ranges from 1.5% to 20.7%. The distance from these hospitals to Wuhan seafood market varies from 1.1 kilometers to 11 kilometers. The nearest hospital to Wuhan seafood market has the highest infection rate of 20.7%, and was among the very first hospitals in Wuhan that admitted patients with COVID-19. The onset of symptoms among the cases was from January 13 to February 5th, and the peak on the date of January 23rd. By comparing the epidemic curve among the public in Wuhan and with that of the orthopedic surgeons in Wuhan, we found that the peak date of onset of orthopedic surgeon was 8 days earlier in that of public. It indicates that this orthopedic surgeon more likely be exposed to COVID-19 in the hospital rather than in the community. According to the response of the questionnaire, the suspected site of exposure were general wards, public place as hospital, ICU, OR, and some community. In the orthopedic wards at that time, and there were several cases in which patients were admitted for elective or trauma surgery during the incubation period of the COVID-19. There were confirmed transmission for these doctors to others in around 1/4 of the cases, including to family members. The high rate, around 1/5 of transmission to family members, raised the need of the doctor to be cautious for the household transmission. We found some risk factors in this study. Severe fatigue of the surgeons during the 2 months before the outbreak of COVID-19 was found to be a risk factor for the infection. The case group has a higher proportion who sleep less than 7 hours per night than the control group. Lack of knowledge of infection prevention and control measure for highly contagious disease among the orthopedic surgeon could be a risk factor. The participation in real-time training on the infection prevention and control measures were found to be a protective factor. According to the questionnaire, lot wearing and 19.5 respirator were found to be a risk factor. It's different from the results of the of some articles. I think the effect of N95 includes direct and indirect effects because orthopedic surgeons normally don't use N95. So use of the N95 is an indicator of the awareness of the transmission, and then this awareness may put these doctors to be more compliant to the infection and control measures. We found wearing respirator or mask all the time is protective factors. Not wearing a mask by patient is a risk factor. Patients normally has compromised immunity. So during the pandemic, the inpatient should wear mask provided by the hospital to protect themselves, fellow patients, and healthcare workers. According to our study, I'd like to give some recommendation. Orthopedic surgeons should be more precautions to avoid COVID-19 infection. And medical and orthopedic association should be prepared earlier to address the uncertainty of the infection and prevention control procedures, provide real-time training, and address the shortage of the PPE. And it's better to minimize perform our cancers on elective operation. And for the orthopedic surgeon who still work in a hospital, it's better to adhere to the recommendation of the infection prevention and control measures. And after being exposed to environment contaminated with patients, orthopedic surgeon should to avoid close contact with family members at home and maintain social distance in other situations. And orthopedic surgeons should try to avoid the long-term overwork and fatigue, which could compromise immunity against COVID-19. Currently, we start to admit the patient and do elective operation. And in our hospital, we use buffer ward to minimize the infection. And all the patient should be tested for chest CT, virus and nucleic acids and antibody before admitted to hospital. If the tests are positive, the patient should be sent to designated COVID-19 hospitals. And if the tests are negative, the patient needs to go to the buffer ward for 3 days and watch the symptom and check the virus nucleic acid test again. If it's okay, after 3 days, the patient can finally go to the general ward for the operation. Now Wuhan has a 0 case of the COVID-19. The city was reopened. Tomorrow, the Electron Tower, the icon of the Wuhan, will reopen after close for 98 days. And the bell of the hope will ring again. Thank you. Thank you.
Yongchao, thank you for sharing your experience. That's really quite remarkable. And I might ask Nadia Jobber to please share the results of the polling. So we had a poll where we were asking the participants to give a sense of the impact of COVID-19 on spine surgery. So if people could please take a few moments and just to click on the impact of this on your practice, and then we will share this afterward. And just while we're doing this, so Yongchao, so currently at what percentage of your elective practice are you at now?
We have around 60% of capacity of the wards,
Okay.
and around 50% of the operation.
I see. Okay. I just see there's another question that's arisen. Oh, there are two questions here. So there's a question, Yongchao, how many younger patients, ages say 20 to 50, did you see in Wuhan, and what were their outcomes like?
The young patient, the percentage I think is around 20%. And normally this patient had mild symptoms, but yeah, but there were several severe cases. And one surgeon in another hospital, Wuhan Central Hospital, died of the infection of the COVID-19.
Oh my goodness.
He was just 34 years old.
Okay, okay, yes. Yeah, I know that the experience in New York City, with which I have a bit of experience, did show that there was actually a substantial number of people between the ages of 20 and 50 in the intensive care unit, much higher than we'd initially had thought. So there's another question from Dr. Pedro. So for healthcare workers previously infected with COVID-19, what are the criteria required in your hospital before they can go back to work? So do you require a negative swab before they can go back to work? You require, an antibody test. What sort of criteria are required?
We in our hospital, we test all healthcare workers before go back to work. And we have test of a chest CT, should be negative. And we test nucleic acids from the swab, should be negative. And also should be negative for IgM antibody. And yeah, IgG is okay.
Right, okay, so the IgM antibody. Dr. Vaisman, are you able to maybe respond to this a question as well? We're not quite as far along as they are in Wuhan, obviously, but do you have a sense of what sort of testing we might require here to allow a healthcare worker who has been infected to go back to work? Not sure that Alon has heard that, but maybe we might be able to address that afterward. There's an additional question here. What was the impact on surgical resident training in Wuhan, Yongchao?
Yeah, and we canceled the training for around 2 months. And all of fellows who went back for the holiday was not allowed to go back to Wuhan. and they should stay at home. And this month, we had them back to work, but we gave some training online for them.
I see. Okay. Okay. Some online training. Certainly, that's an important issue. And then there's a question around the impact of medical comorbidities such as hypertension and diabetes. Is it in your experience that these are important comorbidities, let's say, that might increase your risk of developing an infection from COVID-19?
Yes, I think so. Yeah, because we have a lot of patients with comorbidity like a tumor. They died some of the the COVID-19.
Wow. Okay. All right. Well, Yongchao, thank you so much for sharing your experience, and perhaps we'll come back a little bit later to have a joint discussion. So Dr. Yi, Albert, perhaps I could hand over to you to introduce our final two speakers.
Great. Thank you so much, Professor Wu and Dr. Fehlings. At this time, we'll segue, and many thanks to Anna and Ali for organizing this next section based on some more recent literature in the field. Some articles have been circulated, which include some of the experiences in other areas around the world as well, including Italy, New York, and topics relating to consideration and logistics of spine surgery in this current environment. So it's my pleasure to introduce Anna Reinmuller, who is one of our international spine fellows, trained in Europe, and has a background and interest in biomedical engineering. She'll be the first speaker, and followed by Ali as our second speaker that I'll introduce subsequently. So many thanks again, Anna, and I'll turn the virtual podium over to you.
Thank you very much. I will be sharing my screen. Okay, so for this journal club, we found 4 more key points of importance that we wanted to talk about. The first one is to protect healthcare workers and protect patients. Then we wanted to ensure appropriate patient care, and we wanted to continue the resident and the fellow education. So the first article I wanted to talk about is from the Department of Surgery in Seattle of the University of Washington. So they designed and implemented an emergency restructuring of their resident care teams. And their attempt was to optimize the workforce well-being while complying with the physical distancing requirements and continue the excellent patient care at the same time. But they also wanted to ensure that they not compromise the entire workforce at the same time. So the key points for the restructuring were first, physical distancing, meaning within a team, but also in between teams, by mainly using virtual tools wherever possible. The second was team structure. Out of small individual teams, they created larger independent teams capable to withstand member loss. And then the third part was some sort of a macro structure, which also includes the residents at home in the workforce, but also prepares supplementing members who are affected by illness or by self-isolating measures. For example, with research residents, and the last part was to keep the fluidity of the structure to be able to adapt for changes. So what they did was actually they were merging different services into one service, meaning all the residents, but also all the inpatients, but also outpatients, and the operating needs were merged into one service. And the resident workforce was redistributed into 3 teams, as you can see on this slide. You have the inpatient care team, you have the operating care team, and you have the clinic care team. All the 3 teams are working independently, and they don't cross or overlap to ensure physical distancing. Every team consists of a junior and also of a senior resident, and every member of the inpatient care team has his own workstation, and only one person is rounding on patients. The operating team doesn't participate in any work outside of the OR, and there's a virtual handover between teams. The clinical care team is working from home, using the virtual tools mainly, and they can be used to replace members of the other teams in case it's necessary as a backup. As you can see on this slide, the 3 teams were named Alpha, Bravo, and Charlie, and they will rotate every week, switching residents from one team to another team. Limitations of this study were that the plan was implemented very quickly in response to the COVID. So it was implemented within 48 hours. This system is only possible in larger hospitals, not with smaller hospitals, because you need to cover different teams and sites. There's no information available on the practicability of this setting, because they were implementing the system and we're trying it after. And the only thing that we found that was important to mention is that the system does not work in relation to a case of a positive, COVID positive patient, because then there's more than one team involved in the care of this patient between inpatient and OR. We also had some thoughts on this topic, and our strategy was also to limit the number of people on the service and to implement home office wherever possible. We have 2 groups of residents consisting of at least 1 senior and 2 junior residents, and they're alternating every week, 1 week home office and 1 week on site, including call coverage. All of our residents and fellows underwent specific PPE training, and they follow for sure the current hospital guidelines. We also have a backup list of residents and of fellows to be redeployed from other services, rotations, or research in case of illness or self-isolation. And the last point that we were thinking about that is very important for us is to continue the fellow and resident education, teaching, learning. And this is mainly reassured by virtual tools. So we have citywide rounds, we have virtual classes, virtual training, and the residents and fellows are involved in planning and implementing strategies, and also in research projects in relation to COVID-19. The second article I wanted to present is a review on modes of transmission of coronavirus and proposed measures of mitigation neurosurgery. This is an article that was done also by members of the neurosurgery team of our hospital, Toronto Western Hospital. And I think it follows well in relation to what we've heard so far. So there are three settings in neurosurgery with higher risk of transmission. So the first one to mention is the endotracheal intubation extubation. The second one is during surgeries where we are exposing the respiratory and the digestive tract. And the third one is during the use of instruments producing aerosolization of virulent contaminated tissues. We found it very important to understand the high-risk settings and to implement measures in general and also measures specifically to spine. So the first one of the general measures would be like to operate on as few people as possible and only perform surgeries that cannot be delayed or use alternatives if they're equally valid to surgery. The second one would be involve as few people as possible in the surgical procedure. So keep the number of individuals in the OR to the minimum required to complete the surgery. Do not involve observers, students, or residents who do not have an indispensable role. minimize personal turnover, like making shifts longer, and segregate surgeons in specific hospitals to avoid nosocomial transmission from one hospital to another. And if possible, assign all COVID-19 patients to a single team. And the last part is consider testing all surgical patients for COVID or all patients potentially infected. Specific neurosurgical or spine measures are the following. The first one is consider an alternative to general anesthesia whenever possible. And for transfers to and from the OR and also on the ward, use face masks for patients. And the second one is consider limiting the use of aerosol generating instruments. That means avoid using drills whenever possible, perform decompression and stabilization of the spine with lungers and manual techniques, consider minimal invasive approaches or percutaneous instrumentation, avoid using unnecessary electrocautery, laser, ultrasonic aspirators, protect the surgical field with towels when hammering or irrigation, and irrigate with large volume at low pressure, and use a large suction at the same time. There are certain limitations to this study. So the identified measures to protect during aerosolization procedures have not been tested in clinical trials yet. So they're only suggestions based on biological rationale, and their clinical significance remains unproven. And aerosolization of virin-contaminated blood, or CSF, with bone dust has never been proven so far for SARS-CoV-2 and SARS-CoV. But small changes during surgical procedures might not affect the surgical outcome, but might have a significant impact on disease transmission during surgery. Thank you for your attention.
Okay, that's great. Thank you so much for that overview and your experience. I guess we'll wait for a few folks for either a chat or a question and answers.
I think it's easier that Ali continues right away. I will hand over to him before we answer questions. He will continue with triaging of spine patients.
Okay, that sounds good. So Ellie, I guess maybe we'll turn it over to you. Ellie is a neurosurgery trainee in the UofT program. He's also completing a PhD through the IMS. And let me see if I can find you. Oh, there you are, Ellie. So I guess maybe you can share your screen, and we look forward to your presentation.
Great. So thanks for the kind introduction, Dr. Yi. I'm excited to be here. I see a large group of participants from across the globe, so it's an exciting event. So I'll be talking about the triaging of surgical patients. So with the exception of emergent procedures, most operations are being postponed. And according to the World Health Organization, approximately 234 million major inpatient surgeries were completed every year. And this includes an approximate 5.2 million spinal procedures, as it was estimated in 2017. There are no alternatives to the majority of the surgeries, and deferring surgeries will only make the problems worse for the patients. So essentially, here's the problem. While the coronavirus itself is currently in the forefront, in the background, there's a growing mountain of surgical demand that we will have to face eventually, and this is unprecedented. So we need strategies to triage patients. There will be a bottleneck to surgical care with immediate morbidity and mortality to patients. There is a need for guidance from the literature and organizations to help individual surgeons navigate through the demand that is expected in the delivery of elective surgeries. So that brings us to our first question is, are there any published triage strategies for spinal procedures during COVID-19? The short answer is we have some work that is published as of a couple of days ago, but none are evidence-based, and both of them call for more results and more studies to be had. So the first one I will highlight is from the North American Spine Society, which was published a few days ago. And this was essentially a triaging strategy that their experts put forward. And here it is on the screen. So they effectively divided spinal procedures into three categories: emergent, urgent, and elective. So the emergent ones are the ones that they recommended should not be postponed for any reason. The urgent ones, they recommended that they should proceed if resources allow, and those resources include things such as the availability of PPE equipment and testing, as well as the actual center where this is being done, and with the number of cases that are in the community of that particular center. The third group were the elective ones, which they recommended that should be postponed. So kind of going to the details, starting with the emergent ones, there are three major groups. The first one being those pathologies that have progressive or severe neurological deficit, such as ones due to a tumor, fracture, or infection. The second category they mentioned were pathologies that cause instability at risk of causing neurological damage. This is mainly in the form of trauma. And the third thing they mentioned were postoperative wound infections. The next group category were the urgent ones, and they had four groups of pathologies within that. The first ones were conditions causing myelopathy. Second were infections that failed to respond to medical treatment. Third were conditions with persistent neurological deficits due to compression. And this is different than the first category, in the emergent category, where they had the same thing, but they mentioned there was severe neurological deficit. And the fourth category are pathologies that cause intractable pain or functional limitations that result in multiple emergency department visits or have a potential of causing opiate addiction. The last category were elective procedures that they mentioned that can be reasonably managed without intervention, such as chronic degenerative conditions without progressive neurological deficit. The Rothman Institute has also published its guidelines, and these recommendations are very similar to the ones presented by NAS. They also divided into three categories with essentially the same recommendations. Since they mirror each other, I won't go through them in detail. But both of these have limitations. Firstly, they're difficult to generalize to different fields, and it is ideal to have a system that can be used universally, as spine surgery does not operate in isolation. We have shared resources with other services, and this is a time where surgery as a whole needs to come together to come up with a strategy to triage procedures. Secondly, both systems are based on expert opinion, not evidence-based. And lastly, given the strict categorical system they use, it's difficult to expand the triaging to procedures that were not listed in the original table. So are there any alternatives that have been published outside of spine surgery? There is this recent paper published by Walter Jean in Neurosurgery, which can be applied broadly. They proposed the following strategies. So they essentially have a scale that looks at two things. The first is a time to harmful event if surgery is not done, which is on the top of this, the chart on the left side. And the second is severity of the harmful event if the surgery is not done, which is on the left side. So each surgery or procedure gets a point in each one of these categories. So on this scale, as depicted, a score of 20, which is at the top left in the red, are those procedures that should be triaged first because they're graded to have a severe impact, such as death, in a short matter if the procedure is not done. You can then use calculated deficits for each procedure to identify those procedures that need priority attention. The decision to offer surgery, however, in any circumstance is a balance of the risks and benefits. When doing triaging, you're trying to justify and rank the benefits. Another piece is to consider the risks. So that brings us to our second question, which is, does the current situation with the COVID-19 increase the risk of harm for patients undergoing surgery? So that needs to be factored in our decision-making. So there's a nice paper that was published in the Lancet from Lei et al. In Wuhan. So in this study, they recruited COVID-19 patients who had no known COVID-19 diagnosis or exposure prior to being admitted to the hospital for elective surgery. None of the patients were tested on admission. This was from the early periods of the pandemic, looking at January 1st to February 5th. So they overall assessed 34 patients that were COVID positive who underwent elective surgery. Median age was 54, and the surgeries they underwent is summarized below. Of note, there was one patient who underwent an ACDF who ended up actually passing away due to COVID-19. So the main results are the following. When compared to reports from the same time period in the same region in Wuhan, COVID-19 patients who underwent elective surgery had worse outcomes when compared to those patients who did not have surgery and were hospitalized. So first of all, they developed symptoms much quicker. Average time from onset of symptoms to dyspnea was 3.5 days in this sample. And this is when you compare it to other studies, the average time of onset of symptoms to dyspnea was approximately 8 days. And this is again in Wuhan. The second thing is this cohort of elective patients who underwent surgery had more ICU admissions. So 44% of them who had COVID-19 required ICU admission compared to 26% of hospitalized patients who had COVID-19 without surgery. The last point is they had a much higher mortality rate of 20% when compared to 2.3%. So moving on to discussion. So the patients of this study were likely not exposed to COVID-19 during their hospital stay, but were rather in the incubation period of their disease and asymptomatic when they were brought in for their elective surgery. This is because the median time to symptoms from admission was shorter than the known incubation period of the disease. The authors, with the results of this study, suggest that surgery is a stress to the body and can worsen the response to COVID-19. We know surgery can cause impairment of immune function, and we also know that surgery induces a systematic inflammatory response. These two factors likely alter the body's response to COVID-19 and explain the poor prognosis of operative patients who were operated on when they were in the incubation period of their disease. The results of this study highlight the importance of excluding the possibility of COVID-19 on patients prior to them proceeding to an operation. This can be done via quarantining patients or testing prior to any procedure. Thank you.
Okay, that's great. Thank you so much, Ali. So I guess we have some time for some questions.
Albert, there was a question from one of our participants. Maybe you might want to have a go at this, but this was that there's been a downturn in the number of elective cases that have been done. Do we anticipate that there might be a restoration of elective time, and will surgeons be able to catch up at some point? Well, you know, you're in a leadership position at one of Canada's largest hospitals. What are your thoughts about this?
Yeah, that's an excellent question, and I think probably about 80 to 90% of my Zoom calls over the last few days have been relating to exactly that. You know, I think we're at least in Toronto and in Ontario currently, we're starting to see that, you know, sort of flattening of the curve, and very much in discussion on how we proceed with pandemic recovery planning. And so I think Ali alluded to it quite well. I mean, I think you know, there's a bit of a framework that we need to sort of think about, and there's a variety of models that are potentially available as resources that need to consider procedure factors, you know, PPE usage, general anesthetic, regional, outpatient, inpatient, patient factors and disease factors. And then the other piece that we really need to navigate as well is the ethical piece relating to surgery as a whole, meaning that at least in Ontario, a lot of primary cancers have sort of been unfortunately delayed a little bit. So they are, you know, doing sort of urgent P1 cases, but some of the other priority cases, you know, are starting to get to the very time-sensitive time points. And likewise, we anticipate a huge backlog of cases relating to, for example, in our center, you know, we do about 2,200 hip and knee replacements every year. You know, how are we going to sort of adapt with that? And so we're basically thinking of basically a framework that is sort of transparent, and a lot of this will be guided by looking at obviously our historical volumes and the anticipated backlog. So really trying to quantify that. And secondarily, I think it's really human resource, PPE supply, and in Ontario at least, drugs, anesthetic drugs are also another factor. So those are the key variables that we're certainly discussing at this time. But there are thoughts at some point when things do scale up. You know, we may need to be thinking about potentially alternate models, you know, potentially doing things on weekends, which we may not have done sort of historically. Even I think during this time at our center, we've actually had to adapt and change a bit of a team model approach, and sort of change a bit in terms of the funding model actually to be able to enable the implementation of that type of model.
So we have the results of the polling here. I hope that everyone can see this. So certainly it looks like there has been a significant impact on spine surgery, and 67% of respondents have indicated that they're only doing about 10 to 25% of the cases. And I would say that's probably similar to our own experience at the Toronto Western Hospital, where right now we're doing probably around 20% of the cases. A smaller proportion, 17%, is doing essentially no surgery. I would presume those are for individuals who have a more elective practice. And then there's a smaller group of people where there's about a 25 to 50% reduction in cases, and then one surgeon who is doing between around 50% to 100% of the cases. So it looks like we have Albert. We have a couple of questions up in the queue, question and answer. I don't know if you want to maybe.
Sure. So maybe the first question, and this I guess we'll pool those in the group. So what are the specific triaging strategies that you are currently using at our hospital? You know, I guess Michael, maybe you can comment downtown, uptown at Sunnybrook. We have basically ramped down from about typically 24 operative theaters at the Bayview campus, about 4 to 5 operative theaters at the Holland Center campus daily, down to basically 4 to 5 triage rooms. There's one room that's dedicated to inpatient urgent activity. And then we have a triaging system. Currently, we're doing primarily cases that are less than 14-day criteria. So these would be typically myelopathies, other in orthopedics, time-sensitive fractures, etc. So those are the types of cases, and obviously oncology as well would fall under that category. Basically they're triaged as an entire department of surgery. And I think actually one of the great things actually that's come out of this is that there's been a lot of collaboration and discussions, just recognizing the limitations on resources, and people are really looking at you know, patient-focused care and collaborating and trying to triage as quickly as we can. I guess Michael, downtown.
Yeah. Well, I might actually deflect that over to Anna, our fellow. Anna is spending quite a bit of her time figuring out how to triage. So I guess we have, Anna, we have the on-call, and then we have the cases that are referred to us. So maybe you might share what strategies we're using to triage cases in our practice?
Yes, so we had to change the system a little bit because the triage system cannot be like done in the same way as it was before COVID. So the first thing is that we try to get as much information as possible from the referral, and then get additional information. Then we call patients, see what they actually have as symptoms, and compare this to the imaging, and then we triage into different categories of urgency. So the ones that we just talked about for the level ones with tumors and severe myelopathy or cauda equina, and they're basically clear because they also need to be seen, and they go via the emergency department, get COVID tested, and all the other measures that are taken after follow from there. Then we have the level twos, which are also, for example, tumors, but also nerve compressions, but less severe myelopathy cases, which will go to a Zoom clinic. So after the first phone contact, we will refer them to our own Zoom clinic, which we do instead of our real patient clinic, and assess patients from there with a specific protocol that we try to develop, how to do clinical assessments on Zoom clinics. And then, yeah, it's quite challenging, but I think it works when you try a bit and you establish a protocol, and patients are very happy actually to be on Zoom clinic and to not come over to clinic in person, not only because of the situation today or at the moment, but in general, because some people have to travel quite far, so they're happy about the solution. And then for the less urgent referrals, unfortunately, we have to postpone most of them until the situation has resolved, just because we don't have the capacity of seeing everybody on Zoom clinics at the moment.
Thank you.
But that's how we try.
Ali, if there was a question for you in the article that you presented, where did they assess where the patients got the COVID exposure from?
That's actually a pretty good question, because the main point of this article was not to assess the infection rate of patients in the hospital, but to show the effect of surgery of patients who had COVID-19. So the authors actually try to control for that. So they actually removed those patients who they thought had exposure from visitors. So they actually originally had, I think, 37 patients, and they removed 3 of those patients. So the main hypothesis by the authors is that they all were exposed in the community, and they were just in the incubation period when they came in to have the surgery. So the exposure was in the community.
Thank you. Albert, Mr. Mukherjee from the UK has a few questions.
Yeah, and I think those are excellent questions. And I don't know, we could probably maybe survey sort of globally and maybe ask Professor Wu, and I think there's a chat function if any of the attendees want to provide some personal experience as well. But I think the questions, the few questions actually probably relates to potential delays, you know, either patients fearful of sort of coming in for treatment because of the current situations, or you know, individuals that are having progressive neurological issues while waiting for surgery. And so I guess the general question is, have individuals been experiencing and seeing this as part of their practice? I guess I can start off at Sunnybrook. I think fortunately, at least in my experience, and again, I'm not on call every day, but we do have a team roster. But the periods of time that I have been in and operating and also triaging cases, we have been quite attuned to obviously prioritizing those individuals that are highest risk, and particularly from a neurological perspective. I personally haven't seen somebody come in very advanced, sort of complete cauda equina, fearful of coming in, et cetera, et cetera. I think there are some patients that legitimately are a little bit more concerned about coming in than others. But I haven't particularly run into a situation where there's been a patient that I felt very strongly that should come in that ultimately decided not to come in for a particular reason. I guess, Professor Wu, I don't know if you're still on the line or able to unmute. I don't know if you've had any experiences in China with people presenting with very severe delayed symptoms and issues.
Sorry, I can't use my camera now. And in my city, during the severe time of the COVID-19, like February, there was some delay of this kind of emergency surgeries. And because of the capacity of the operation room is the issue, and we need to have some test like a CT scan and virus test before the surgery, and there's some delay of the time. But we do did some this kind of surgery, but the time number is was limited, and some issue about this problem is about the problem of the transportation. There's some limitation of the transportation because the ambulance is fill of duty to some other more emergency situation. So I think this is another issue.
Mm-hmm.
There's a comment from Christina Goldstein in Colorado, one of our former Toronto fellows. And Christina, it's not really a question, but she's just indicated that a number of patients have not wanted to come into hospital right now for elective surgery and have asked to push their surgical treatment a bit later. Anna, certainly that's something we've noticed in our practice as well.
Yes, absolutely. I was screening patients on the surgery list or on the waiting list for Dr. Fehlings, and there were a few patients that were getting worse in terms of their myelopathy symptoms, decreasing their MGA down to 11, but they absolutely did not want to come into the hospital or even get assessed by Zoom clinic because they're too scared and they don't want anything like to do with the hospital until the crisis is over.
Yongchao, have you noticed that? Are any of your patients afraid of coming into hospital for treatment, or is that not as much of an issue culturally in your country?
Yes, and I made a lot of appointments before COVID-19, but I think around 80% of the patients cancel the surgery by themselves. Yeah, because the symptom is limited, or they can they just don't want to come to Wuhan to do surgery.
Dr. Yi, I think there's a question from one of our current fellows.
So I don't know, maybe Ali, if you may want to, if you run across this in any of your readings, there's a question specifically relating to OR, I guess room temperature for viral control, if there's any literature on that or suggestions. I don't know that we've really changed much, at least at Sunnybrook, based on our experience, but not sure if that's something that you've seen or run across.
I haven't come across that in the articles I read. I'm not sure the temperature settings.
I wonder Alon may not be on the call anymore. Mm-hmm. Yeah, so I'm not sure that I've come across this. We have a question in the chat from one of our fellows, Colby Ointment, and this relates to kind of the timing of urgent or emergent care. And I might ask this of Dr. Wu and Dr. Yi. So with variable sensitivity to COVID testing, if a patient presents with progressive neurologic decline in a pending COVID test, should we proceed with the surgery anyways, rather than waiting for an affirmative test? Dr. Wu, what would be your approach, and Dr. Yi in Toronto?
And for emergency surgery, in February and March, we normally we did chest test, chest CT scan. That's very fast, and it's better to understand the situation. I think it is okay to the delay of the time. It didn't take much time. And after the emergency surgery, we will do a final test.
Albert, what's your approach at Sunnybrook?
I mean, I think, you know, obviously you may be pressured depending on the clinical and neurological sort of situation. I think if you had time, opportunity, you like to get the test back if at all possible. We have had some delays in getting the test.
Yeah.
And so forth. And so they're not always available that rapidly. There has been, and there is a little bit of variation in terms of how different hospitals have approached the ACE-GMP criteria. So at our center, none of the spine surgeries are considered ACGMP, and therefore sort of N95 full protective type of situation. And it's basically based on the argument of it being a droplet, and that although it can be detected in blood and feces and things like that, there's at least a Canadian Blood Services a memo that went out indicating that at least those particles or what's detected are not viable, and so unless you're physically drilling or burring into you know, a nasal cavity or a pharyngeal cavity for a spinal procedure, you're not under that a full sort of using that COVID room. I don't know if anybody's actually operated on a COVID positive patient here in Toronto. I know one of our pediatric colleagues has down at Sick Kids, and you know, when you have all the equipment on, it's you know, to sit there for a 6 or 8 hour case. I mean,
Well, you know, it's interesting. It varies. Toronto Western, we're considering any procedure where a burr is used on the spine as aerosol generating. So, you know, it is a bit of an adventure to do that. We have a question from one of our alumni in the UK, Mario Ganau, who brings a Canadian, Italian, and UK experience to this. And Mario has asked, this is a question for you, Dr. Wu. Have you had any experience with patients that were initially COVID negative and you operated on them and then they convert and they're COVID positive? And do you have a sense of what the complication profile looks in any of those patients? An interesting question.
Yeah, I myself didn't have any experience, but my colleague in our department had this kind of case, and they did spine decompression surgeries for the patient, and 1 or 2 days after the surgery, the patient had a fever and tested positive for the COVID-19. All the patients recovered very well, fortunately. And 1 fellow and 1 resident got infection from that patient.
Right. And there's another question from Dr. Ganau around COVID-specific M&M rounds. Wow. Albert, are you doing COVID-specific M&M rounds? We are not, fortunately, to date, doing that.
Yes, I mean, I'm sure that will be coming in different formats. The one actually element of all of this that actually has worked out quite well and we've been able to enjoy, I think, in and around the city in Toronto as well, is the ability for virtual rounds and a lot of interprofessional multi-level education. So we're no longer really limited by, physical ability to travel to different centers for rounds and so forth. And so the participation in some of our rounds has been superb and excellent. And, I think obviously quality assurance rounds and things will be following suit as well.
Okay. Okay, very good. All right. Any final comments from any of the panelists? I think I'm not sure Alon is still on, but Dr. Wu, any final comments from you?
I think according to the appearance in Wuhan, the future is bright, and we will have get back to the surgery soon, and the situation is will be getting better, I think. Thank you.
Very good. Anna and Ali?
I just want to mention that I think this is unfortunately not going to be the last pandemic we're going to be going through. So as someone who's a researcher, I think we have to use this opportunity to enrich ourselves with information, so the next time this comes around, we're better prepared.
Anna?
Yes, I totally agree. I think that it's very important that we are prepared and that we continue to be prepared. And I think the use of virtual clinics and more virtual tools are useful for everybody, not only for us, but also for patients. And we can continue using that, although there's no pandemic anymore.
Well, I think as in any crisis, there's always innovation that evolves, and there will be innovations that will occur in our clinical management of patients. Well, Albert, it may be time to draw a close to our journal club. Big thanks to all of our speakers for wonderful presentations, very focused and succinct and evidence-based. And Nadia Jabber, our program coordinator, many thanks as well. Albert, final comments from you?
Yeah, no, I think it's been excellent, and I certainly learned a lot. And I think there's a lot of opportunities where we can share our experiences. I think different parts of the world, different regions are going through different phases of this pandemic. And so we can certainly learn from others that, have sort of already flattened the curve and are already scaling up in terms of their activities. It's great to recognize so many names on the attendees list from all around the world. And so it's great to have that interaction. I also want to acknowledge and thank our industry partners as well, many of whom signed on and are supporting our program. And we look forward really to continuing our efforts together as a group as we navigate through this period of time together. I think we will have, I guess our traditional end of academic year Spine Fest, typically in June, will be another innovative type of virtual format as well. So I just want to thank Nadia again. She's done a great job helping keeping all of us in line and organizing all the IT and capabilities for us this evening.
Thanks to Nadia, and many thanks also to all of our alumni for attending. It's wonderful to see all of you participating, and a heads up everyone for our Spine Fest in June, and we'll be sending out the announcements. And on that note, wish everyone a good evening or a good morning or a good night wherever you are in the world, and please be well and stay safe. Thank you very much.